Hello there. Good afternoon, or just turning afternoon, I guess. This is Nancy Byatt. I'm the medical director of MCPAP Vermont. Thank you for joining today. And today, Margot Nathan, one of our consulting psychiatrists, was actually the person who created these slides and had been planned to present today. Unfortunately, she is home quite sick and not able to present today, so I'm stepping in. But I just want to thank Margot for creating all of these slides and for the great work she did on creating these, and I'll be doing the presentation today. And Margot will, I'm sure, likely present at an upcoming webinar. So today what we're going to be talking about is updates in perinatal psychiatry, and specifically I'm going to talk about sleep management and new innovations in postpartum depression treatment. And also just to say that, if you guys have questions, you can put them in the chat box or say them, and then we have our MCPAP for Moms team on the call, so they'll let me know when there's questions. And but I'm happy to have this be interactive and to have questions throughout as you have questions. So the goal for today is to review the clinical presentation of perinatal anxiety and also the treatment, and then also talk about perinatal sleep disturbance, which often goes hand in hand with perinatal anxiety. And then also I'm going to give an overview of some new strategies we have available to treat perinatal depression, which are very new, that are specific for postpartum depression and perinatal depression. So starting with perinatal anxiety. So anxiety is a common complication of pregnancy. It actually occurs in 20% of women during pregnancy or the postpartum period. So it's really very common. And similar to depression, it's been linked with adverse maternal, obstetric, and also neonatal outcomes. So for example, in pregnancy, it's been linked with poor self-care, increased risk of postpartum depression. And then for obstetric outcomes, miscarriage, preeclampsia, preterm delivery, low birth weight. And then for kids, it's been linked with disrupted attachment or bonding, and then also with an increased risk of kids of moms who have maternal anxiety, or increased risk of having their own anxiety or disorder, or of ADHD. So these outcomes are all very similar to the outcomes we see for depression. So when we think about treating depression, anxiety is getting sort of more attention recently, less studied overall, less attention focused, but equally it's also very common and can have these negative outcomes and has been linked with negative outcomes. And often what happens is that, when women present, they're often worried about pregnancy, childbirth, and the maternal world. Like, I actually saw a patient yesterday for MCPAP for Moms, and this particular woman had a history of anxiety and said, she's like, I am so worried about the baby. She's like, her mother apparently had 7 miscarriages, and she just thought she was destined to have a similar experience. And she was just really had all these intrusive, anxious thoughts around, her worry that she'd have a miscarriage, and her worries that she could also have a loss. And similarly, that can happen like when people have OCD. So I'll talk a bit more about OCD, but one example is I saw another patient recently who had OCD, and for her, one of her obsessions and compulsions was she had a thought that the baby was not going to be viable, and she kept like putting her phone to her belly, to her abdomen, in order to be able to hear the baby, and she was literally doing that all day. So really, often when women are pregnant or postpartum, their concerns about the obstetric outcome or the child outcome can really sort of manifest itself in the themes of their anxiety. And I'll provide some more details on that later too. And then often, this sort of is very intuitive. What can happen is when you're experiencing anxiety, it can be associated with impaired adaptability and also difficulty with infant soothing. So for example, people can have trouble responding to novel situations. So often what happens is people, they can't control the baby, right? So if a woman's, and especially for someone who's a new mother, or if it's a second baby, they often, if they can't soothe the baby can't stop crying. That is anxiety provoking for anybody. And then if someone also has, it can often precipitate an anxiety disorder. And then also a lot of times what happens is people sort of have a more mild anxiety disorder that, it's impacted their functioning, but they've been able to kind of still function every day and work and do things. And then when they have a baby, there's all these things they can't control, and it rocks, people's lives. And then and then it can be really hard to know to kind of how to cope with, especially if a baby is, if there's difficulty soothing the baby. And then what you could see as a result of this sort of impaired mother-baby attachment, or attachment is another word we use for bonding. So the other reason that anxiety is really important is it's a major risk factor for postpartum depression. So in general, about 2/3 of women with perinatal depression are also going to have anxiety. So if you're, for example, working in an OB practice and you're seeing patients with depression, about 2/3 of women are also going to have a comorbid anxiety disorder. So that's really important. And I think a lot of times, you know, it can be hard to differentiate the two. And also when people present with perinatal depression or postpartum depression, there's often a lot of anxiety as part of the depression too, and they can have comorbid anxiety. So it's really, you know, often the two go hand in hand. So, you know, ACOG recognizes this, and so they actually recommend screening for anxiety at least once during the perinatal time period. The GAD-7 is a tool that can be used to screen for anxiety. It asks about generalized anxiety. There's a couple other tools that I'm going to talk about, but really they do recommend screening, and the GAD-7 is one option for screening. That's very quick, it's self-administered, and can be very useful. So you might be wondering, well, okay, ACOG recommends screening. Like, what are some of the risk factors? Like, should I screen everybody? Should I be screening women who, or should I be screening women who I suspect are at risk? So my general thing, ACOG recommends screening universally at least once, and that's what I would generally recommend. And I think often it's helpful to do that, combine that with screening for depression, because you're often screening for both. And you may be wondering, well, how do I know who's at risk? So it's very similar to actually who's at risk for depression in a lot of ways. So social, these are similar risk factors for depression: low socioeconomic status, a lack of support, and someone with a history of trauma. So someone who, you know, presents, who has those factors is often at risk. And then for obstetric risk factors, so for example, someone who presents having unplanned pregnancy, or if they have a medically complex pregnancy. They, you know, women understandably really want a healthy baby, and they want to be healthy for their baby, and when it's medically complex, that understandably can cause a lot of anxiety. And then for psychiatric risk factors, so anyone who has a history of a prior mood or anxiety disorder is at very high risk of anxiety, and also if they have a high perceived level of stress. And the way the word is perceived stress. So, you know, we all have stress in our lives. No one can, like, we all have that. But people perceive stress really differently. So what may feel stressful to one person may seem a lot less stressful or more stressful to another person. So it's not necessarily about what the stressor is. It's more about how the person perceives that stress. And that really does vary depending on someone's, you know, depending on many factors. So you might be wondering, okay, so, you know, say, for example, you're working with somebody and you've screened them, or you're thinking, okay, are they at risk of anxiety, and you're beginning to wonder if they have an anxiety disorder. So there's many different kinds of anxiety. I think a lot of times, I know when I often talk to obstetric providers or obstetric, you know, healthcare professionals when they call our program, we often kind of say, oh, they have anxiety, and like it's not necessarily specific, and we wouldn't expect, you know, OB providers to be discussing their specific anxiety disorder, because that's definitely the role of psychiatry. But just to kind of have an awareness that there's a lot of different types of anxiety disorders. So there's panic disorder, which is where people get like an acute onset of anxiety that occurs either out of the blue, or it occurs in response to like for example, being in a closed space, like agoraphobia. And that typically involves a lot of physical symptoms. So that's panic disorder. And people often worry about having those panic attacks. They can be very immobilizing people. Specific phobia, that's where people have a phobia against one specific thing. It could be blood draws, it could be animals, it could be spiders. That's just having a phobia for one specific thing. Social anxiety is where people are worried about being in social situations. For example, they go to a social situation and they worry that they're going to embarrass themselves, and then they avoid those social situations, or they endure them with great distress. So that's very specific to social. Generalized anxiety is where people are generally feeling anxious, and they do what we often call catastrophize. So they predict that bad things are going to happen, and then that understandably makes them feel very anxious. So for example, they might be going out to go do an errand, and they think, I'm going to go out and do this errand, I'm going to crash my car, and then this bad thing's going to happen, and then it kind of is like, it's this they have these litany of concerns that they can't control, and then it takes over. So often the way we talk about anxiety is it's this thing that can kind of like literally hijack somebody's brain. And the way people experience anxiety is often as an intrusive thought that they just can't control. It's this thought. Patients often say, women often say, I know that this is going to happen, and I know that like that is never going to happen, but I can't stop worrying about it. They may worry they're going to get into a car crash. They may worry the baby's going to die, but they know it's not going to happen, but they can't help but worry. So it really can hijack people's brain and be very distressing. OCD is when people have intrusive thoughts and then a compulsion to get rid of that intrusive thought. PTSD is when someone has a history of trauma and then symptoms related to that, which we'll talk about later. And then also acute stress disorder. That's PTSD, but that has occurred for less amount of time. So it's typically in the first months, and that may or may not turn into PTSD. And I'm going to go into a little bit more detail about OCD and PTSD a little bit later, because those are, particularly PTSD is very, very common during this time period. So as I kind of alluded to, symptoms of anxiety disorder can be both psychological and also physical. So as I mentioned, with panic disorder, people have an absolute physical reaction. They really feel that they are going to die. They often end up in the emergency room. They may get ruled out for an MI because they feel muscle tension, heart racing, palpitations. They may experience GI upset, shortness of breath, headache. They may get paresthesias. They may feel they can feel their heart racing, they can get diaphoresis, so they really feel they have a physical experience, and they often really feel like they're going to die. And it's very, very scary. And even if so panic disorder, I think, is an example that has a lot of physical symptoms, but anytime someone has any of the anxiety disorders, it physically affects them. So, for example, with generalized anxiety, people can experience they just feel tense. They may sort of see something or if they're worrying about something, then they may feel that their heart's racing a bit. Not as severe as maybe with panic disorder, but with all these anxiety disorders, there's definitely some physical component, and it really takes a toll on their body. So the other things that can happen is you can have all these psychological components. So I mentioned, for example, with generalized anxiety, we see excessive worry. People can feel on edge, and it can be difficult to reassure them, even though they know it's not. Intellectually, they know it's not going to happen, but they can't control the anxious feeling. And then often what we see is that the sleep is very disrupted, and that because they're often up at night worrying about these things, and it's hard to go to sleep. And I'm going to talk more about sleep later. And then also people experience intrusive thoughts. So with a lot of these anxiety disorders, the thoughts are very, I'd say actually with all of them, the thoughts are very intrusive. As I mentioned, it like comes in, the thought like hijacks their brain, and they can't get rid of them. That's why it's difficult to reassure them. So, and these intrusive thoughts are one of the most distressing symptoms. So I'm going to give a couple of case examples of intrusive thoughts, and these are actually really common. So, for example, what we often see is that people who have anxiety, we also see this sometimes with depression, where they have thoughts that, for example, I'll give you a case example. I saw someone recently who had these thoughts. She had a history of, she had OCD, depression, and she had this thought of throwing her baby down the stairs. It was this intrusive thought that would come into her head, and she couldn't get rid of it. And, she had no intention of doing it. She knew, she came in and she said, I know this is a bad thing to do. I don't want to do it. I spent half my day pacing across to the other side of the house and avoiding the top of the stairs because I don't want to throw my baby down the stairs. This thought was scary. It was intrusive. And she had good insight. She knew it was a bad thing to do, and she wasn't psychotic and so forth. Someone like that is actually at very low risk of acting on those thoughts because it's what we call ego dystonic. It's making them anxious. So, and that we often see that. That's an extreme example, but we see that with a lot of things. Like I mentioned that woman who was, constantly putting her phone to her abdomen in order to see if her baby was okay. She had this intrusive thought that would come in and say, your baby's dead, and then she would have to constantly check her abdomen. She spent all day doing it, and it was this obsessive cycle that she couldn't stop. That's like a very, very common thing. So the other way to differentiate that is that people can have other kind of thoughts. So for example, with postpartum psychosis, people can have thoughts, but they aren't as scary to them often. So for example, give a case example, there was actually someone who several years ago this is a well-known case, that was in a newspaper at the time. It was an attorney who was from Brooklyn. She had this delusional belief that her baby had a traumatic brain injury. She took the baby to a lot of physicians. They all said the baby's fine. But she thought that the baby fell one day. The baby did fall, but the baby was fine, no traumatic brain injury, but she thought she caused it, and she thought that her and the baby were destined to a life of torture. Everyone, you know, and the difference here was that she had a delusional belief that she caused it, and she thought that the baby was destined to a life of torture, and her reality was distorted. So with the differences, with the person I described, she knew it was a bad thing to do to throw the baby down the stairs, and same with the woman. She's like, I know my baby's fine, but I can't help get rid of this thought, and I can't help but check my belly all the time. With this other attorney I'm describing, it was very different because she had a thought that this baby had a traumatic brain injury, but she believed that it happened, and she couldn't reality test. That's the big difference here. She couldn't, she heard that reality was distorted. It wasn't just an intrusive thought, her reality had changed. That's when you differentiate between an illusion and an intrusive thought, a delusion and an intrusive thought. So in that case, she actually jumped out of a very high-story building in Brooklyn, holding the baby actually. She died and the baby actually lived. So that's an example that's postpartum more consistent with postpartum psychosis. Really important to differentiate the two because these intrusive thoughts are actually very common and most women are not going to act on them. And these people don't necessarily have to go to the emergency room. So this slide is actually here to reassure you because postpartum psychosis occurs in 1 in 1,000 women, whereas these intrusive thoughts that can sometimes be focused on, you know, something bad happening to the baby or harming the baby are actually much more common. And they don't necessarily, the women are not necessarily at high risk of acting on them. So other thing that's important to think about when we're thinking about anxiety is post-traumatic stress disorder. So when we're evaluating anxiety symptoms, it's really important to think about PTSD. So to have PTSD, someone has to have a history of trauma, and that doesn't have to be like sexual trauma or physical trauma. It can be they witnessed someone physically threatened or hurt. They witnessed an event where someone else was physically threatened or hurt, or they thought their life was at risk. So the definition for trauma is often wider than we may think. And, you know, often what people experience is nightmares, so they re-experience it in some way, by the way of flashbacks, nightmares, intrusive thoughts. The other key thing is that they often have avoidance. So they avoid things that either remind them of it or they just kind of withdraw in general. And this can be where it overlaps with depression. And then they can also have hyperarousal or hypervigilance. So they can, you know, if something reminds them of that trauma, they get really anxious. So some people often say, oh, if someone, you know, looks at me the wrong way or if something reminds them, they can also get very irritable. And sometimes they can dissociate. That's when somebody actually loses time and doesn't necessarily remember because they have dissociated for a short period of time. And this can often be accompanied by depressed mood. So as I mentioned, you know, there's a lot of screening tools for anxiety. PTSD, this is a screening tool for PTSD that asks about in the past month, have you had nightmares? This can be really useful. And I think, you know, as I mentioned, this is very common during this time period, so it can be really useful to screen for PTSD. So the other illness that I mentioned earlier that I want to go into a little bit more detail about is OCD, or obsessive compulsive disorder. So women with OCD are at very high risk of exacerbation during the perinatal period. So onset of illness can occur during this time, or it can worsen. So I actually seen a couple of patients recently who both presented with probably, they were both in their early 30s, had probably OCD for about, you know, 10, 15 years, but, you know, had kind of fallen under the radar and hadn't ever really been diagnosed or treated because they kind of had managed it by, you know, cleaning a lot and, you know, but they were still able to function. Was it impacting their functioning? Absolutely. But they were still able to function and get through their day and function at work and keep their job and so forth in their relationships. When the baby came, or in one case when they became pregnant, it just became to the point where they couldn't function. Like one woman had to stop working because she just couldn't, you know, she was spending hours cleaning her house. She couldn't leave the house without just spending hours cleaning it. And another woman, similarly, also couldn't work because it just became so much worse. So you often see either an onset or an exacerbation during this time period. The good thing about OCD and PTSD and all these anxiety disorders is from a medication treatment perspective, it's very similar to how we treat depression. So pharmacologically, there are a couple differences which I'll talk about, but in general, we use the same type of medications, which is, you know, antidepressants. And also, you know, the mainstay is to refer for therapy as well, which I'll come back to later. So, and you know, there are, again, the good news is there are evidence-based treatments available for treating for treating anxiety, all these different anxiety disorders I'm talking about, and letting women know about the different support options is really important. So there's medication treatment, and then also individual therapy and also group psychotherapy can be helpful. And please let me know if you have any questions so far. You can just put it in the chat box, and then Beth and Sarah, let me know if people have questions. So I wanted to just remind you about our program, MCPAP for Moms. We provide trainings, which is what we're doing here. If you have someone that you're seeing, definitely call us. We're happy to consult with you about women and talk to you about, any questions you have. And then we can also help with referrals for treatment if you call us as well. So you don't have to remember all this today, because, you can always call us with these questions. We're here to help. So when we think about pharmacological treatment, as I mentioned, it's very similar to treatment for perinatal depression. So in general, SSRIs are considered the first-line medication treatment. And another treatment, specifically people have PTSD, is trauma-focused therapy. That's another evidence-based treatment for PTSD, of course. One thing to be thinking about, just to be aware of with pharmacological treatment for anxiety disorders, is that people often need higher doses. So, for example, with anxiety disorders, people may need higher doses and they may not respond to the same type of dose that may be a therapeutic dose for someone with depression. So that's something to consider. And also, I would just add that if someone has comorbid anxiety depression, definitely for psychotherapy is a first-line treatment option. Always should be offered, in my opinion. It's also important to think about when you have the two illnesses, chances are that there's a stronger chance that medication treatment may be indicated. So I would generally recommend more strongly considering medication treatment if someone has comorbid anxiety and depression. And general antidepressants are considered the first choice, as I mentioned, and SSRIs in general are very well studied during this time period. So when we think about what are the prescribing principles, when we think about preconception, pregnancy, and breastfeeding. So in general, you want to use a medication that's worked. So for example, if somebody presents and they're 11 weeks gestational age and they're on a medication and it's working, we generally do not recommend stopping that medication to start a new one. And the reason why is because if someone's on a medication and it's working, they've had one exposure, right? They've been exposed to that. They've been exposed to the medication. If you stop that medicine and start a new one, you're definitely going to double the exposures because now they're exposed to two meds, and you could potentially triple their exposures because you don't know if that second med is going to work. So I'd say including Paxil, which sometimes people worry about the most. If someone's on a medication and it's working, as far as antidepressants go, we typically wouldn't change it during this time period. You really want to minimize switching medications. And I would say that goes for a lot of other psychotropic medications as well. So the other thing that's important is to use the lowest effective dose. So you definitely don't want to, I tend to be conservative with medication. However, you also don't want to undertreat because then you're exposing the patient to both, and the baby to both illness and the medication. So ideally, you want to not undertreat them, but you also want to make sure that you're not, giving them unnecessarily high doses. If you can have patients on one medication, it's best. There's definitely even more emerging evidence recently that if someone's on multiple medications, the risk of each of those individual medications goes up. And so if you can have someone on one medication, that's definitely preferable. And then the other thing that's really important is that as the pregnancy progresses, there may be a need to adjust the dose because as the pregnancy progresses, you have a lot of pharmacodynamic, pharmacokinetic changes, metabolic changes, and women may need a higher dose. So, for example, I was once working with someone who had, she was taking Celexa, and she was on 20 milligrams, and she'd been doing fine, and then she came in at like 30 weeks gestational age and was like, nothing's changed, it's just like it stopped working. And she needed it bumped up because her metabolism was changing and she needed a higher dose. And then often you can go back to that dose after delivery. And then generally, there's no evidence to suggest stopping SSRIs before delivery because we definitely know it increases the risk of relapse, but there's no evidence that's actually going to help birth outcomes. So people often ask us about benzodiazepines, because benzodiazepines are, definitely people can use them for anxiety, and often, people often consult us around this, and often people are already on them when they may, for example, present for their first prenatal care visit. So in general, I try to minimize the use of benzos whenever possible. However, sometimes people need to be on them, especially if someone comes on them, it can be very hard to get them off. So typically what we do, the possible risks of using benzodiazepines in pregnancy are of cleft lip or palate. It's been linked with preterm birth, low birth weight, and also with, this neonatal withdrawal syndrome. Some people have talked about risk of floppy infant syndrome. That's sort of, I believe, quite controversial, but you may hear about that. Generally, we think more about neonatal withdrawal syndrome, which is where they may be tachypnic, go to the special care nursery, be jittery, and so forth. So the general guidelines, so those are the possible risks. What we generally recommend is if someone is on is anxious, it has an anxiety disorder and needs treatment, we generally recommend optimizing an SSRI first. So if someone presents and says, I want a benzo, I would always recommend to do an SSRI first, typically. If someone is so anxious that they really can't function, and for example, they're not working, they can't sleep, then it may be reasonable to try a benzodiazepine. And generally, the reason we use benzodiazepines, if we use them in the short term while we're waiting for other treatments to take effect. For example, psychotherapy and an antidepressant treatment. Antidepressants do take 2 to 4 weeks to work. So definitely, if you can avoid a hospitalization or help someone function, or if they haven't slept in a week and they need to just kind of break that fight or flight syndrome, then that's a very reasonable way to do it. They're not meant to be long-term treatments, and I don't recommend kind of starting these with the understanding it's going to be long-term treatments, but they can be very, very helpful in the short term. If you are going to use one, we generally recommend using ones with fewer or no active metabolites, for example, lorazepam or Ativan. The thinking is those may be safer, and to avoid longer-acting benzos, for example, like diazepam or Valium. Similar with breastfeeding. I would say the same things apply. You want to use, generally the shorter acting the medication, the less passage through the breast milk. So another mainstay of treatment when we think about non-pharmacologic options is CBT. So, therapy, as I mentioned, is a mainstay of treatment. CBT is a very evidence-based treatment. We know that it works during this time period. And the whole premise of CBT is that we kind of have, thoughts, behaviors, feelings, and when we have thoughts, that they make us anxious. The goal of CBT is to change thoughts so you no longer feel anxious. So for example, someone who has generalized anxiety disorder might think, I'm going to go out, I'm going to crash my car, then they feel anxious. Of course they feel anxious because they believe they're going to crash, they have this intrusive thought that they're going to crash their car. If that thought can be changed with therapy to, for example, to be, well, I'm going out, but what's the evidence I'm going to crash my car? And they can change their thoughts so they don't have this intrusive thought they're going to crash their car, then then the goal is they'll feel less anxious. So that's the goal of CBT, to change people's thoughts so that they don't feel those anxious feelings. And it can be used for depression as well. So other non-pharmacological options, and these are generally what we consider support options. I wouldn't recommend, if someone comes in and they have an anxiety disorder and they're having trouble functioning, you wouldn't really do these instead of treatment. They are adjunctive to treatment that can be additionally helpful. So meditation, for example, there's some great free apps out there, like Headspace is a great app that can be used for meditation. There's other apps. Then just mindfulness in general, progressive muscle relaxation. Yoga actually has an emerging evidence-based for perinatal depression, anxiety, and other things, for example, are acupuncture. And then other really important things that can be done is encouraging people to exercise if they're, of course, able to and it's medically appropriate. That definitely has been linked with preventing or reducing anxiety. It is recommended by ACOG. Also important to protect sleep. So, for example, taking daytime naps and having support from family or friends with the baby. This can be critical because often women, feel like they have to be the only one breastfeeding the baby, and if they can accept support from family and friends or even ask for that support, that can be really useful. So really important to be sort of encouraging women to do that. Other things that can be anxiety provoking where you have an opportunity to support mom can be around anxiety and stress. So it can be around infant feeding, which can cause anxiety and distress during this time period. So for example, supporting the mother's choice of feeding. So my general thinking of this is that breastfeeding is great if women can do it and it's a positive experience for them and the family. That's a wonderful thing, and we always generally recommend breastfeeding. However, breastfeeding should not trump mom's mental health. If mom, and we see this all the time, and I'm sure you all see this, if mom is struggling, to breastfeed, and it's really impacting her mental health, sometimes I really believe it's our role to help mom let go of that if that's appropriate and that's her choice, but help her make a choice that's going to be best for her and baby. And often the mom kind of doesn't think about their needs because they're so focused on the baby, but if they totally ignore their needs and they're really, really suffering to breastfeed, it sometimes creates a really negative cycle and isn't always best. So it's really important to think about, there's times when mom's mental health needs to trump the breastfeeding, and that's okay. So really important to be sort of encouraging both mom and also family and friends to be really taking a supportive stance around that, and sometimes allowing mom to let that go if it's becoming something that's no longer productive and is really impacting her mental health, because then ultimately that can have an impact on baby's health too. So kind of, letting mom know that ignoring her needs is not doing her or her baby any good, that's not good for her and her baby. The best thing she and her baby can do is, get the help that she needs, and sometimes, that may be making some hard choices around breastfeeding. And then also making sure that she has support from family and friends to breastfeed if that's something she wants to do and she doesn't have to do it on her own. So I'm going to switch now to talking about perinatal sleep disturbance. This is super common, and I'm sure that all of you see this all the time. So sleep disturbance in general is it's one of the most common perinatal complaints. So in general, over 60% of women report sleep difficulty during pregnancy. And it's also a major risk factor for postpartum depression and anxiety. So really important that this gets addressed. And, one of the things to do when you're thinking about this is to be asking about sleep onset and duration, asking about quality of sleep, asking how many times you're waking up. Is it difficult to fall back to sleep? Are they alert during the day? Are they snoring? Is there any limb movements? And also if the symptoms are impacting their daily functioning. That helps determine, where would you guide any intervention around this? So, the reason, as you see, I talked about, snoring, limb movements, things like that, the person may have a sleep disorder. So I've definitely seen people that my main recommendation has been they need a sleep study. So getting a, polysomnography can be really helpful, because what you don't want to be doing is kind of like trying all these behavioral interventions or prescribing sedative-hypnotics if the patient has a sleep disorder and it's missed. So that's really, really important to assess, because that is very treatable. And then also checking, iron studies can be helpful, and checking a thyroid, because hypothyroidism can certainly look like hypothyroidism can certainly have symptoms, cause a lot of symptoms consistent with depression. Hyperthyroidism can cause symptoms consistent with anxiety. So I would say in general, whenever you're working with someone and you're thinking of starting a medication for anxiety or depression, always important to do check thyroid functioning, because that's something that can absolutely cause very similar symptoms. And I've worked with people. I once had someone present to me with a very, very high TSH. She was on a high dose of Zoloft, wasn't getting better, and then once we treated her thyroid, she got better. So you don't want to miss that. So, because, you could keep titrating antidepressant, but if the thyroid's not addressed, it's not going to work. So there's also, screening tools for depression and anxiety. So if someone has, this is the EPTS, which we use to screen for depression, and it has some anxiety subscale, so it does have some anxiety questions. So that's an option that can be used for depression. And can get at some anxiety, and that's why it's a little better. Some people consider it better than the PHQ-9, because it has those anxiety questions that can get at anxiety. So and I've definitely seen people screen positive on this that don't necessarily have major depression or a depressive disorder, but they score positive just because of anxiety. So if someone presents with sleep complications or sleep complaints, often it's a really good opportunity to screen for depression and anxiety, because it could be, having difficulty sleeping can be absolutely a symptom of an anxiety disorder. So if someone's presenting with this, you'd want to screen for this and see, okay, well, is this part of a bigger thing? So you're not kind of you don't want to be treating one symptom of a larger illness. You don't want to be just targeting their insomnia if insomnia is part of an overall anxiety disorder, which it often may be. So, and because poor sleep quality is a common symptom of both postpartum depression and anxiety. You could see it with both illnesses. People generally have less total sleep time. It can take longer to fall asleep. They can spend less time in REM, and they also can have non-restorative sleep if they are experiencing depression and anxiety. So really important to screen for that. And then also, poor maternal sleep, this is pretty intuitive, is also linked with 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 the baby not sleeping well. So often if you're addressing the mom's perinatal sleep disturbance, that can have a positive impact on mom and baby, because if the mom's up and anxious, then often the baby may be too, because often they sort of feed off of each other. And so, you could let mom know that, that's part of why it's so important for her to get the support and help she needs, because it's not just going to benefit her, it can also benefit the baby. Hopefully she wants to do it for herself, but sometimes they don't. So often the hook to get people motivated is, you need to do this for yourself, but also it's going to be best for you and the baby. So when we think about, what are the treatments of sleep disturbances? So really it depends on what is the cause of the sleep. So I think it's very tempting, and we see this a ton in primary care settings where someone presents and we kind of, they have a sleep, they're experiencing insomnia, and then it's prescribing is easy, right? We have it in our toolbox and we can easily prescribe. I would actually say that, medication can be used in certain circumstances. I would say this is not a first-line option for sleep. What we know works best for sleep is actually behavioral treatments, which I'm going to talk a bit more about in a minute. So, and also sleep hygiene, which also I'll talk more about. When medication is indicated, I would say if someone, like I gave that example earlier about when we use a benzodiazepine, I would say it's very similar. So if someone, I'll give a case example. I saw an OB called MCPAP for moms, and this person had an EPDS of 19. The OB called and said this patient, has no history of depression or anxiety. She's really suffering. She's like, she hasn't slept in 2 weeks, and she's just so anxious. And the OB provider was thinking of she had started her on Zoloft and thought, this is, because she was really struggling and thought, well, she must have an anxiety disorder. I ended up seeing the patient for a face-to-face consult within a few days. And in the meantime, the OB had started her on a little bit of a sleep medication. She'd given her Ativan 1 milligram QHS. So by the time I saw her, she'd gotten 3 good nights of sleep. I saw her about a week after the OB had originally prescribed Zoloft, and then in the meantime, because the patient called back again, increasingly anxious, and the OB had given her this 1 milligram Ativan. So she had 3 good nights of sleep, and it was amazing. Her EPDS was a 7, and she was doing so much better. So I think that's an example of this patient was really, really struggling, and she got a few good nights of sleep, and didn't actually need the Zoloft, and didn't actually have an anxiety disorder or a depressive disorder. So that's one example. It can also happen where that symptom could be part of an anxiety or depressive disorder, where they may still need to be on the Zoloft, but they can at least get to work and function and take care of themselves and their baby. So that's an example where a benzo has a good use, and also if you're doing it until a medication can take effect, until either behavioral treatment can take effect, or until if they do have depression, anxiety, till that actually takes effect. So use it in the short term. And there's other options. Just to be clear, I've been mentioning benzodiazepines a lot because those are the clinical examples I have. There's a lot of other things that can be used for sleep. Benadryl, people often use hydroxyzine or Vistaril, and there's other, options for sleep. So I definitely would say benzos are the first option. I've just been using that as an example. Just want to clarify that. So, as I mentioned, I think of medication as something that's really not to be used as a first line. It's really to be kind of kept in your pocket in case other options don't work. So what we generally recommend, and what we know has the overwhelming evidence for sleep, is behavioral treatment. So and really healthy sleep habits. We refer to this as sleep hygiene. So I'll give you some examples of sleep hygiene. And studies clearly show that in the long term, this is what helps. In the long term, sedative-hypnotics like benzodiazepines and other sleep medications like Ambien, Zolpidem, all those kind of things, they generally worsen sleep quality in the long term, and patients develop tolerance to them. So they may work in the short term. That's why they can be used in the short term. In the long term, they are not effective in the long term in general. So what is effective and has clear evidence base is things like sleep hygiene. So I'll give you some examples. You can tell women, keep the room dark and cool. So don't tell women don't be on your iPhone with the lights on when you're going to sleep, which amazingly, a lot of people do, right? Those iPhones are pretty, or whatever smartphone they're using can be pretty seductive. Limit screen time. So a lot of times people recommend after you have dinner, keep the lights low and don't go on the screen at all. No TV, no smartphone, no screens after dinner time. And then minimizing caffeine and alcohol. So this may be not having caffeine after noon, and alcohol certainly worsens sleep quality. and don't watch the clock. So a lot of times people say, you know, if you're sitting if you're laying in, the only thing the bedroom should be used for is sleep and sex. So if someone's in bed and their mind's racing and they're anxious, if they're not, and they're starting to watch the clock, if they're not asleep within 20 minutes, get up, go do something, and then come back when you're feeling tired. So you don't want to be in bed tired and anxious with your mind racing. If you're not tired and you're starting to watch the clock, get up, go do something, and go back when you feel tired. So only be in bed when you're tired, because otherwise they associate the bed with someone where they're anxious and tossing and turning. And also have a regular sleep schedule. So a lot of times people say, you know, they think, oh, I'm going to catch up and I'll like sleep till noon when I have a chance. Even if people are exhausted, get up at the same time every day and go to bed at the same time every day, because you can really regulate your sleep-wake cycle that way. So that's kind of things that you can all do and, you know, talk with your patients about and recommend these things. The other, what's a more formal treatment is CBT for insomnia, which we often is referred to as, the acronym is CBTI. And this is where there can be a demonstrated benefit for sleep disturbance during pregnancy. This also has a very, very strong evidence base. It's less studied in women with anxiety, depression, or there was some recent data though showing that it was effective, and that there was some recent data actually showing this that can be that it can be helpful. And, you know, obviously it's difficult to implement in the postpartum period because, you know, it's so complicated by the baby and having to get up with the baby and so forth. But the goal of this is that to get out of this vicious cycle of poor sleep. And as I mentioned earlier, where you're kind of using cognitive techniques to change negative thoughts so they become positive thoughts. And that's the goal of CBT in general, cognitive behavioral therapy. And there's definitely evidence for this helping with sleep during pregnancy. And postpartum, it may need to be adapted, of course. So other sleep promoting strategies that can be useful is meditation. Like there's a lot of great apps that have specific meditations for bedtime that can be helpful. A lot of these apps are free. Mindfulness in general, exercise. When people have like, you know, exposure to light during the day and they're out and they're exercising, they're more likely to sleep better at night. And also getting support with infant feeding from family or friends. So as I mentioned, there are some pharmacological options, you know, antidepressants. So a lot of times what we do is if somebody has, for example, a sleep disturbance, we may make an antidepressant that's more sedating. So mirtazapine, the other name for it is Remeron. That is an antidepressant that is that we often use that is quite sedating. So that sometimes is a good option that can be used. If you are starting antidepressant, insomnia is a major complaint, you know, sometimes we pick antidepressants that are a little more sedating. And I'd say mirtazapine is probably the most sedating antidepressant we have available. And, you know, and in general, if you're treating the underlying depression or anxiety, the hope is that that will also help with sleep. And then TCAs, which are tricyclic antidepressants, those can also be used. They're a little more complicated. If you're thinking of prescribing a TCA, definitely give us a call. But some of those can be quite sedating and be potentially useful. And, you know, as far as their limited safety data, in general, we talked earlier about using these in pregnancy. And in general, you know, these medications, Ambien and Lunesta, are like these, they stimulate similar receptors, but they're viewed differently than like medications like Ativan, which are more classic benzodiazepines. But you know, these medications ultimately have quite a few side effects. People can actually have retrograde amnesia. I once worked with a patient who was taking Ambien and who literally would go out, drive, and like have absolutely no recollection the next day of what he did. I once worked with an elderly woman who'd been prescribed it, who would wake up and when she found like a huge butcher knife and a cake on the counter, and the cake was completely eaten. She lived by herself. She woke up in the middle of the night, ate a huge cake, and there was a butcher knife on her counter. It scared her. It understandably was very horrifying to her in the morning, because she's like, what could I have done? So these are, you know, they have uses, but they can be, you know, they need to be used with caution, and especially when you got a postpartum woman who's like got a baby and you can have this retrograde amnesia. I really am very conservative with these medications in general because of the limited safety data around them, regardless of sort of pregnancy status or lactation status.
And before you go on, we do have a question for you.
Oh, cool, great.
One of the biggest challenges I see among pregnant and postpartum women is that I work with is medication interferences with breastfeeding. I'm aware the Hales book that refers to medications in mother's milk. However, I'm wondering if there are any additional recommendations for moms who are suffering from depression and really need, really want to breastfeed and prescribe, and are there prescribed medications that are contradictive to breastfeeding?
It's a great question, yeah. So in general, I would say, so as far as antidepressants go, these are generally pretty safe in breastfeeding. Like the general thinking on this is that the risks, the benefits of breastfeeding outweigh the risk of any passage through the breast milk. And you'd have to, I once read an article that you'd have to breastfeed exclusively for 2.5 years to equal 1 month of exposure in pregnancy. So once a patient's been on like an antidepressant during breastfeeding, it generally does not make sense to stop it postpartum or to switch it. And generally the thinking is that, you know, the benefits of the breast milk outweigh the risks. If someone presents and it's their first, you know, episode of depression or anxiety and they've never been under the medication, we typically would choose sertraline or Zoloft because that does go through the breast milk less. The shorter the half-life, the less passes through the breast milk, and Zoloft has a short half-life. Prozac, for example, or fluoxetine would be our last choice probably because that has a really long half-life of like 2 weeks. That said, if someone came in and they were on Prozac and it was working, I wouldn't switch it because you want to use what's working. Same principles apply in pregnancy and lactation. But if someone's, you know, those generally can be used. With other medications, so with like benzodiazepines, for example, you know, I'd say a lot of ways it's similar to pregnancy. We try to avoid those if we can. If I'm working with someone and they're really, really anxious and, you know, it's kind of those case examples I described earlier, I've absolutely prescribed benzos during pregnancy and I will continue to do that if sort of the benefits outweigh the risks. I generally don't recommend pumping and like what people often refer to as pumping and dumping because, you know, I do find that it makes women very anxious. We used to sort of recommend this years ago quite a lot and we'd say, oh, take the medication, like, you know, pump and dump and then take it later or what have you. But like it makes people really anxious and it makes them very, very focused on it. And just the act that they're pumping and dumping kind of makes them, I think it brings attention to the medication going through the breast milk, and I think overall, the benefits of doing it don't outweigh the risk. So I generally don't recommend that. I recommended it when very early on, when I first started practicing in this field, but I don't anymore. And let's see, and another really helpful resource, medication in mother's milk is great. There's another very helpful resource that can be really useful called LactMed. It's free. It's put out by NIH, and if you just put in like the App Store, it's LactMed, LACTMED. You can look up a drug name, and it will come up with how much it goes. It's a little bit different than Hale, the medication in mother's milk, but it actually will like summarize what studies are there. It's a summary of basically all the most recent studies. But I find it very user-friendly, and it's great because I'm with a patient, you know, we all have patients that we see that are on a med that we maybe, you know, that we don't prescribe as often or what have you, and it's really great to be able to look that up. And you can literally just sit there with the person and kind of talk about what the risks and benefits are. So I would say that's also a really useful app that can be helpful. Let's see. So I'm just going to switch gears, and we'll have a little bit more time for questions at the end, I think, to talk about some of the more recent strategies for treating depression during this time period. So currently, we have, as I mentioned, antidepressants, the mainstay of treatments. We also have, you know, psychotherapy. Sorry, I meant to say psychotherapy is the mainstay of treatment, antidepressants when indicated, and all these support strategies we've talked about. Previously, you know, we were really using things that were kind of developed for, especially from a medication standpoint, we were using things developed for general major depression and, you know, using them for pregnant and postpartum women. They work for general major depressive disorder, so, you know, there's definitely, you know, we translate that evidence to pregnant and postpartum women. More recently, there's been a new medication that is specific for moderate severe postpartum depression. And this medication is called Brexanolone. The brand name is Zulresso. And it's a medication that was just FDA approved in March, and it became available in June. So it's exciting. It's and what Brexanolone is, it's a proprietary formulation of allopregnanolone, and it acts on the GABA A receptor, which is similar. Like when we talk about, you know, benzodiazepines and a lot of these kind of mechanisms we've been talking about, the GABA receptor is really important in general when we're thinking about psychiatric treatment. What's new about Brexanolone is a very fast onset of action. As I mentioned, with depression, antidepressants generally take 2 to 4 weeks to work, right? And that's why I mentioned we're sometimes using like a benzo in the meantime or what have you. And, it's a long time for women to wait when they're home, they got a brand new baby, and they're struggling. It's just a long time for someone to suffer. This has a clinical benefit within 1 to 2 days. So within like 48 hours, people feel better. And the way it works is that, and what's happened with Brexanolone is that of the women who get better with Brexanolone, and it's for depression, it's not FDA approved for anxiety, it's FDA approved for depression with its onset in late pregnancy or in early postpartum. And when people do have a reduction in depressive symptoms, that reduction is maintained at 30 days. And this has been demonstrated in 3 placebo-controlled trials. So if this is their EPDS score, and basically what happened was if someone has an EPDS score, the EPDS score goes down, and then and if they do go into remission, it maintains at 30 days postpartum. Sorry, 30 days after the initial infusion, I should say. So this is all great news. The tricky part of Brexanolone is that it's an IV infusion. So that makes it hard because and it needs to be continuous IV infusion. They are currently testing a version by mouth. It'll take several years for that to be available. And so because it's an IV infusion, it needs to be administered in an inpatient setting. So there is some centers popping up. I'll come back to that in a minute. And the other thing that complicates treatment with Brexanolone is that one of the side effects, I don't know if it's a common side effect, but it's a side effect, is loss of consciousness. And so what happens is, and in the studies, the women didn't, for example, women might have a syncopal episode. They weren't like unconscious needing to go to the ICU, but there was a couple of episodes in the studies where women had, were sitting there, thought, I feel dizzy, and then had to sit down. And in one case, there was a syncopal episode. So, if someone's postpartum and they have a baby, obviously that needs to be taken really seriously. So that's what complicates it, is that it's an IV infusion and that, there is a side effect of loss of consciousness. So people need to be also monitored continuously. They have to have a continuous pulse ox, for example. So it's not yet done in outpatient settings. They're hoping, I think, at some point that will happen, but that would be quite a bit down the line. Other common side effects include headache, dry mouth, dizziness, and sedation. And so a lot of what's happening with the centers is there's definitely centers popping up. There was actually a recent article that I think it was, if I'm remembering correctly, it was either the Mayo or Cleveland Clinic where they started a Brexanolone center. And we're currently, I'm at University of Massachusetts, and we're currently in the process of getting one established at our institution. I don't believe we have any open in Massachusetts yet. I know that Brigham is working on developing a center. UMass is, and I believe that Beth Israel is too. So they will become available with time. Currently, they're still sort of working on it. And so that's in progress. But it's very exciting, and there'll be more to come on that. And if you have questions about this and you're wondering, are the centers opened up, what's happening with it, would someone you're working with be a good candidate for Brexanolone, definitely give us a call. We're happy to talk to you about that and help you figure out who would be a candidate for it. So in conclusion, perinatal anxiety, it's common. We know it has a negative impact. It's very treatable. And, we have multiple screening tools available, both for generalized anxiety, PTSD, and, if you're going to screen for illnesses, we generally recommend anxiety and PTSD because those are the most common. We have evidence-based treatments, including therapy, medications, and other supportive strategies that we've talked about. And, it's really important to evaluate when you're thinking of, if someone presents with a perinatal sleep disturbance, to evaluate what's the cause. So, for example, is it a sleep disorder? Is it environmental? Is it, or is it due to another or is it a symptom of a larger psychiatric illness like an anxiety disorder or a depressive disorder? And that will then guide the treatment. And it's really important to think about it that way rather than treating the symptom. And then, as we mentioned, that what works the long term for sleep is these behavioral treatments and like CBT for insomnia and therapy. And again, really important when you're talking with women, letting them know that improving sleep it's not just for them, it's for their baby too, and they should hopefully want to do it just for them, but, you know, it can be helpful for the baby. And then, you know, we have these new treatments available like Brexanolone for postpartum depression, and the goal of Brexanolone is it's targeting the underlying pathophysiology. It's sort of getting at, I think the thinking is it's getting at the pathway a bit earlier than like SSRIs do, which hit the serotonin receptor. Because Brexanolone sort of is targeting a different part of the pathophysiology. And we will have more info, and we're happy to talk to you about those being available if you have questions, and about who may be eligible for that medication. So I don't know if we have any more questions. I'm happy to, I think we have a couple minutes left for questions.
Yeah, I think we just wanted some just to repeat the name of the app that you were referring to with the breastfeeding.
Oh, sure. It's LACT Med. So it's LACTMED. Yeah, and it's put out by... Yeah,
yes, there is and the slides will be available on our website. Usually we post them in 48 hours. So check back later this week, and we will be happy on our website on MCPAPformoms.org.
Great. And I just want to thank Margot for her slides, because she created these slides, so I just wanted to acknowledge her again for, you know, we were, you know, unfortunate that she wasn't feeling well enough to do this today, and, you know, for creating a nice presentation for us, and you'll probably hear from her soon. Are there any other questions?
I don't believe so.
Okay. All right. Well, thank you, everyone, for attending and for participating, and hopefully we'll see you at the next webinar. Bye. Thank you.
Thanks.